welcome everybody to Conversations in Health. This is our first in-person session of the year because 2 weeks ago we had a snowstorm, so for the first time in the history of this course we went on Zoom for a reason other than the pandemic. So welcome everybody. As a reminder to everybody who's going to be watching this or is online, this is a class where we bring together leaders in health, like Dr. Seshimani, who will share with us both her journey, but also help us engage in some of the really important issues of today. She's had an amazing life, an amazing career, but we'll get to that.
Okay.
Soon. But I thought, but the other thing, just is a process. What we'll do is we'll have a little conversation at the beginning. I'll open it then up to the class, and then if there's interest of folks either online or people who aren't enrolled, we'll call on you, and we will end no later than 7:30. So I think I'd like to start at the beginning. So it'd be great. We always ask everybody to give a little, like, where did you grow up, and a bit of your educational background, and just give us a quick update about where you're from and a little bit how you got here.
Sure.
Imagine you were here at one point in your life.
I mean, I didn't have these options for these incredible majors. I feel like we could spend the whole time just talking about, what you all are studying. I would learn so much.
Imagine how I feel.
Yeah. So I grew up in New Jersey, actually, and now I live in Bethesda, so not too far from Potomac. I don't know if you went to Churchill.
I did, actually.
Then you have to leave right now.
Are you WJ?
Yeah, no, Whitman. Yeah, my son is a freshman at Whitman. So he's a volleyball player, and he's totally mapping out which of his volleyball teammates from the club teams are going to be going to Churchill and which are coming to Whitman so that he can figure out, like, who's going to win in the games. Anyway, so I grew up in New Jersey, and when I was going to college, I thought I was going to be a bio major. I was interested in being a physician. I had done a lot of volunteer work in the hospital, and I wanted to have that way to interact with people. So I thought I was going to be a full-time practicing pediatrician, and that's exactly what happened.
So you did, in fact, major in biology.
No, none of it. None of that happened. So I took an econ course my second semester freshman year, and just to do like the econ basic, just so that I can know the basics for managing my own bank account. And I ended up really loving it, and I ended up switching my major from bio to econ. And I did and then I was like, well, how does this fit? Because I was still very interested in the life sciences and interested in medicine. And at the time, there was a grad student who taught a course in health economics, because health economics was a very new field. So that kind of dates me, but it was a very new field. So there was one person who was finishing his PhD and decided to teach a course in health economics. And so I said, okay, well, let me see what this is like. And actually, in that course, we ended up studying the Clinton healthcare plan. If any of you studied that, that's what I studied, about how what would have worked, what didn't, what were the things that led to
failed.
It tanking. I wasn't implicating you. And so that really kind of sparked my interest in how can I maybe bring these things together. So I went on to medical school. I thought, okay, well, that was a fun detour, right?
You were undergrad at Penn, right?
At Brown.
Brown, okay.
Yeah. And I realized just how much I missed the economics. I was never meant to do basic science. I do still remember the mnemonic for the Krebs cycle, though, which I'm very proud of. That's about all I remember from biochemistry. And so I had also done a course on international health systems as I was finishing my undergrad. And so I ended up applying for scholarships, and I got the good fortune to go to England, and I did my doctorate in health economics, basically on a leave of absence from medical school. So I did an MD PhD, but in a very non-traditional way. So then I did my doctorate, and then I was like, well, do I want to go back and finish med school? And I thought, no, I really like taking care of people, and I don't like the spreadsheets and all that much. So I went back to finish med school. So I thought, okay, now I didn't want to be a pediatrician anymore. I'm like, I want to do internal medicine because I don't know if any of you are interested in medicine, but internal medicine, especially when I was going through, was like, that's what people in health policy did. So I arranged all of my clinical rotations. So I would do surgery first. So then I would do really well in my internal medicine rotation. And I did my surgery rotation and I really liked it. And I thought, oh, if I like this, I'm just going to love my internal medicine rotation. And I get to my internal medicine rotation and I'm like, no, this is not for me. So then I had another like, okay, so now what do I do? And I ended up doing an elective in otolaryngology, ear, nose, and throat. And really liked it. So all of a sudden, instead of being a bio major pediatrician, I was now an economist, ear, nose, and throat surgeon. And one of my mentors at Penn, the late Sandy Schwartz, who was an internist. I mean, it was only internists, doing this kind of work. And I said to him, I said, what do I do? And he's like, well, you know what you have to do. You really like it, so that's what you should do. And you'll figure it out along the way. But again, at that time, when I was applying for residency, I was applying at one esteemed program, and the chair of the department asked me in my interview, prove to me why the research you do matters. Because everyone only did basic science research, and here I had done research on how the Balanced Budget Act of 1997 impacted, post-surgical complications, but that was something that was completely foreign to the vast majority of otolaryngology residency programs. And I ended up going to Hopkins because the chair at Hopkins at the time, when I had my interview with him, said, we need to get more surgeons into health policy and healthcare management and healthcare leadership. I think it's really important that we expand and that we take some risk because, it's a risk for them to bring someone who's, different like me on board. So I went to Hopkins, and during my research time, because we all had research during residency, I did my research on how the U.S. healthcare system is financed. And very, very related to hearing and smell. So I did how the U.S. healthcare system is financed. I did a research project on how employers make decisions about whether to provide health benefits to their employees or not. So I remember the head of our research, Paul Fuchs, God bless him. We would all have meetings where we had to talk about the research we're doing. It would come to me. He's like, I don't even know what you do, Mina. You just do what you're going to do because no one could give me feedback or anything. So through that research, I ended up working with Senator Daschle, who ended up getting named as the health secretary for President Obama, and Jean Lambrew, who was going to come in to lead health reform efforts. So Jean actually reached out to me and said, hey, we're going into the administration. Would you want to come and continue to work with us? And I said, well, I'm in my residency. I can continue to work on papers when I'm in the call room, on call, but I have to do my training. And it just so happened, like a few days later, that my residency program director sent me an email. It was like 9:30 at night. Hey, so all of the faculty were meeting to talk about all of the residents, and we were talking about how Senator Daschle was named for Secretary of Health and Human Services, and didn't you work with him? Do you think there's a chance that they might want you to go to Washington to work on, healthcare? So I called him at 9:30 at night. I was like, Dr. Flint, wait, are you being serious? Because they actually called me and I told them I couldn't go. And he's like, don't do that. We can figure this out. So the chair of my department and the residency program director got me a leave of absence so that I could go to DC and work on health reform. So I make all the arrangements. I go down to DC, and then Senator Daschle steps down because of a tax issue. So then Dr. Flint's calling me, we still have your spot in residency if you want to come back. But at that point, I thought, I'm here. I might as well just see what happens for a year, and I can always, just have the experience and go back. And then Secretary Sebelius was nominated, so I worked on her nomination prep, for her hearing. And then she asked me and Jean to stay and start the Office of Health Reform at HHS. And that is where I met John Monahan in, what was it, job number 15 of 22?
Exactly, yes. I've been my second tour of duty at HHS.
Yeah.
We were all excited when you agreed to do this.
Everyone
thought for sure you were gone when Daschle stepped down.
Oh, really? I didn't even know that.
Because, it seemed like the moment advanced, we got lucky.
So now I learned something new. But I mean, it really was. And I mean, after that, I worked for 2 years. We passed the Affordable Care Act. I worked on initial implementation, like all of the initial regulations. And then actually, I don't know if you know this, Larry Summers, who was head of the National Economic Council, asked to meet with me. I literally waddled into his office. I was like 38 weeks pregnant. And he offered me a job at the White House to become the special assistant to the president for healthcare at the NEC. And I called up Lloyd Minor, my mentor, who at this point was provost at Hopkins. And I said, I don't know, what do you think I should do? And he said, well, like if you leave residency at this point, that is a door that you are closing. So I think you really have to think, is that a door that you want to close? But this is an incredible opportunity. So then I talked to Secretary Sebelius, and her response, and I think this is totally on character for her, she was like, well, if you don't go back to finish your residency, I'll fire you. And then you'll have to go back to finish your residency.
That is how she is.
Yeah, right? Because I think at the end of the day for me, I really did enjoy that interpersonal, experience, and I wanted to have that be part of my career. So I went back, finished my residency. I was practicing full time in California, and then Secretary Sebelius and Jean reached out and said, we want to do more on how we change the delivery system. And so I ended up going back into the administration. That was my second tour. So you all see this was all very well planned out. And then I went to MedStar. I was like, okay, that was fun. I'll go to MedStar, and now this will be, where I will have the rest of my career. I was practicing at Georgetown, and
we are lucky to have her here, too.
And I stood up care transformation at MedStar because there was really no, coordinated strategic population health. There was community health, case management, all of these disparate aspects in the various hospitals, but nothing actually bringing it together. And nothing.
Just one footnote is MedStar is a network of hospitals.
Oh yeah, it's not just Georgetown.
That includes Georgetown Hospital.
Mm-hmm. It's 10 hospitals, 300 outpatient sites. I think it's like $6 billion.
So the building you see off Reservoir Road is just a piece of this. It's one of the 2 or 3 largest networks in the Mid-Atlantic, right?
Yeah.
And so it's huge. So just a little context for you. So please, I'm sorry.
Yeah, but I think to be able to coordinate all of that together so that you can have lessons learned across the different hospitals and communities to collect resources together, but also to then be strategic with health insurers and with the government, right? So like we were able to approach CMS on, how we were taking care of our seniors with the Independence at Home demonstration that I can talk more about. Or we set up a palliative care pilot with CareFirst Blue Cross Blue Shield, where, they give us a lump sum of money per patient to do a team-based approach to care, which I'm sure will not be surprising that when you get chaplains involved and social workers, and these are people who can't bill for services, but the services are very important. But you need to make the economics work so then you treat people with dignity and the way that they want to be treated, and it saves a lot of money in the process. So you improve outcomes and it saves money. So that's the work I did at MedStar. I helped lead the COVID response while at MedStar. And then I was asked to work on the Biden campaign, and then asked to help lead the transition when Biden won. And then, I expressed at that point my interest in going back in to the administration. They said, well, which jobs would you be interested in? I said Medicare, because I knew that there was a lot going on with Build Back Better, that they were looking at expanding the benefits that are under Medicare. They were looking at drug negotiation, which was historic. So I said that's what I would want to do. And so then that's where I went. So it really, and now, so then I left.
And guess what?
Because, I kind of had to leave, right? Because of the election. And then I was asked to become Secretary of Health for Maryland. So now I'm, starting that process to start April 8th. So there's really, this was not like some set path that I had at the outset. And I'm always, I'm always in admiration of people who come to me for career advice and they're like, so this is what I'm planning out and this is what I'm doing and does this make sense? And I'm talking to this person so then I can get to know that person. And I'm like, God bless you, because all I did was just roll up my sleeves and work hard and try to figure out what I loved to do and to do a good job and to enjoy working with people. But I honestly think that's the most important thing, because life will throw you curveballs. If you haven't had a curveball thrown at you yet, it is going to happen. And I think, it's just being able to navigate and keep your eyes open for where your heart is telling you that, hey, this is a place where I can really put my shoulder to the wheel and have impact. So,
have you seen a theme now across our present? So I think you'll find.
Oh yeah.
I think you'll find this is how lots of you'll see that as a theme through our leaders. But there's one piece. I mean, it's amazing, and just I so appreciated working with you, and people so admired. When you came into government, you weren't sure what you were getting yourself into.
No, I was literally, I was Googling reconciliation and cloture. I had no idea what any of those terms meant or anything.
Half the transition was filled with people like me who had spent years in this agency, and then we bring in but new people. You caught on pretty quickly, to say the least. But one thing that I think is really distinctive about your career is the fact that you've remained a practicing physician.
Yeah.
And I guess one thing that you hear people talk, certainly physicians are among the most vocal commentators on our health system and financing. I guess do you think that's been a huge asset for you? How do you think it's changed how you think about your policy work?
It absolutely has. So in my long rambling answer to your first question, when I went to Kaiser and I was practicing full time, that was the first time that I thought I knew what my career was going to be for the rest of my life. I was planning on working at Kaiser, going into leadership, right? That was going to be my plan. And then second time was, at MedStar. Always taking care of patients it's so grounding. Mm-hmm. When I was at MedStar, I only had clinic on Fridays, and I used to say that I had a 4-day work week, and then Friday was my fun day, because I just got to take care of patients. I had, one older gentleman, he's from Sicily, and so he would go back to visit his family over winter break, and he would always bring me these Sicilian lemon cookies, and I think those things are very important and grounding when you're then working on thorny policy issues, right? I had to implement the biggest piece of legislation to impact Medicare prescription drugs since the Part D program was created in 2003, and given 2 years or less to do it. And the only way that I think we really managed as a team was that we kept in mind, why are we doing this, right? I had a woman right here in the Georgetown Hospital in my clinic where she was on Medicare. She had this, draining ear, bad ear infection. I had to keep trying different antibiotics and things like that. And she told me, she's like, I can't afford the antibiotic you're prescribing me. So I examined her in clinic. I did something in clinic so that would be covered. And then we got on our smartphones on GoodRx, and I was trying to figure out what antibiotic I could prescribe for her that she would afford. So what I wouldn't give to be able to pick up the phone and call her now and say, hey, Mary, guess what? Now you don't have to pay more than $2,000 in a calendar year for your prescriptions, right? Or I led the diabetes management program. And, so many of our diabetics that were getting readmitted to the hospital, it was because they had a behavioral health issue as well. Because you can talk to people about taking insulin and, diet and exercise. But if they can't even get out of bed in the morning because of their depression, then you are not taking care of them, and they're going to bounce back to your, emergency room. So now in Medicare, there are payments for behavioral health services that are provided as part of a primary care office visit. So a lot of the things that we did in Medicare really came directly from my own experiences taking care of patients. So, and it was really important to me also that we listened to everyone, because when you're sitting in your office and you have a spreadsheet in front of you, that's not flesh and blood, right? And there's a reason that it's called the art of medicine. There is definitely an art to it. Mm-hmm. And knowing what goes on the ground from all the different perspectives, from the patient to the clinician to the health plan to the pharmaceutical manufacturers, that's all really valuable information, because they have a view that you don't have as a policymaker. And I told everyone when I met with them, I'll know I'm successful when at some point I have upset every single one of you, because that's the nature of these jobs, right?
Exactly.
But at least you're giving me information so then I can try to thread the needle and figure out what to do with what is $1 trillion a year in healthcare claims. And I think being able to navigate that, mm-hmm. Also I think the fact that I did do my training, practiced medicine, I think was really important. And I think the last thing is, when things would get really stressful at work, people said, "Oh, you were always so calm. You're always so calm, and you don't get flustered." I'm like, that's because no one's dying in front of me.
It does put things in perspective.
My very end of my residency, I had a patient that I got called into the hospital because he had got stabbed with a knife through his cheek. It had gone back to his spine, so the handle was sticking out, and they had to operate on him, but nobody could open his mouth because of how the blade was. So I had to do an awake intubation on him, with him flailing around and all this stuff. A PowerPoint? Come on.
So it gives you perspective as well as informs your work. That's awesome. That's good. I love it. That's an image that's going to be hard to get out of my head. So the knife going through. One more question, and I'll turn it to Morgan to kick us off. But the other thing, though, is you now are playing it. You've played in some pretty intense policy debates.
Yeah.
With very powerful interests. And I'll be honest with you. I never thought we would get to the day where Medicare would be negotiating prescription drug prices. And you were right there in the middle of both the design and the implementation. I guess. One of the challenges we know in our system is that, and this is what happened with the Clinton health plan. I mean, a failure to engage with the opposition that was going to come from industry. Something different happened this time. I guess I would love your reflections on where the pharmaceutical industry is now. You've done, how hard was that, and what are your thoughts given the new policy environment?
Well, I actually would say I didn't view it as engaging with the opposition. Okay. I mean, the pharmaceutical industry does incredible work, right? I mean, when you talk about step changes in how we care for people, it's incredible what biotech and pharma come up with. I mean, I was working on policies to enable cell and gene therapies to be provided to people with sickle cell disease. I mean, you're talking about things that can cure these, intractable diseases. And so for me, it was much more about, okay, what are the things that are concerning you about the legislation so that I can take that into consideration as I'm implementing? And where do you see opportunities for you as well? Because, decreasing someone's out-of-pocket costs for prescriptions means more business for the pharmaceutical industry, right? So it goes both ways. And so it was very important to me from the outset that we really met with everyone, from patients to, clinicians, health plans, drug manufacturers, from the big pharmaceutical companies to the smaller biotech companies, to say, okay, what are the things that excite you? What are the things that you want us to do when we implement? What are the things that you don't want us to do, and why? Where do you need clarification, or where is there confusion? What are you hearing on the ground, either from patient groups, from, investors? And I think that was very important for us to get all of that information because it enabled us to implement in a thoughtful way where, our goal ultimately was to implement this law so that you can meet the common goal, which is that people have access to the innovative cures and therapies that they need. Because someone who's going into biotech, someone who's going into pharma, a patient, a clinician, everybody wants people to get healthier. That's why they go into healthcare. But along the way, the market may not be working as well as it could. And this is where the health econ, comes back out. So where can we utilize drug negotiation to try to address some of the existing, market dynamics that maybe are not lending itself towards that ultimate goal? So there were a lot of conversations about what is the value that drugs bring. There's a big difference between a Me Too innovation, right, where a drug is different but not by a lot, versus a breakthrough innovation where you are now really drastically changing the lives of people who have a disease and really engaging the pharmaceutical industry in that conversation. And so the negotiation program really was founded on how can we get more real-world evidence to help guide what impact these drugs are having. Because I don't know about you, but my life is not a randomized controlled trial, right? And to judge everything on this controlled environment doesn't necessarily give you true insight into the impact that a therapy can be having on communities. And so it really was an opportunity to have real life people come forward and say, hey, this drug works great for this reason, or, taking this drug 4 times a day is really difficult, or the mixing that I have to do is really tough. And, I think there are many ways in which drugs can bring value that aren't necessarily captured in the randomized controlled trial, through the FDA process. So, and we worked closely with the Food and Drug Administration too, in okay, how do we kind of get to this next level of data? So, we had very productive meetings with, the pharmaceutical companies, the biotech industry. Do they like everything? I don't think anybody, again,
If everyone was happy,
then you didn't tackle the tough things, right? Like at some point you're going to make decisions that people don't agree with you, but that means that you're actually tackling something tough. And I think one of the best takeaways that I had, I think it was in my last week at CMS, and we had a stakeholder meeting, and someone said, I just want to commend you and your team for your professionalism, how approachable and responsive you were. We didn't agree with everything you did. We didn't like everything you did, but we understood why you did it, and we could still see where our feedback was being utilized, so we knew that you were listening to us.
Kudos to you all for the way you got the industry to move to talk about individual products and the way that they make a difference in people's lives. I worked on the Medicaid rebate in 1990. The industry was still at a place where, please stay away. We'll discount some programs, but not down to that level. And I think what you did was really extraordinary. I'm glad that they responded. So now we'll open it up to the class, and so I think we'll kick it off. Morgan, do you want to start us off, and then?
Yeah. First of all, thank you so much for being here with us, engaging in this conversation. I wanted to ask you more about your time at CMS. In particular, what were the biggest challenges or hurdles you faced when advocating for these policies for the people that you really thought were necessary during your time as a physician? And were any of those challenges sort of related to the bureaucratic system within the CMS?
Yeah, so I think one of the biggest challenges is healthcare is very complex and it's very personal. And that combination means that it gets very emotional very quickly for people, and it's hard for people to wrap their heads around what policies might be, what programs might be. And so being able to communicate and explain to people what's going on to get them to engage with you, I think is always a challenge. Not everybody wants to hear from the federal government, right? So a lot of the things we did was partnering with local communities because people would much rather hear from someone who lives in their area, who looks like them, right, who understands their needs, rather than reading a CMS pamphlet. And so I think that definitely was probably, continues to be a challenge. Also that gets kind of tied up into rhetoric that can, be thrown around. Like, how do you make sure that you are getting important information out for people to be able to make, their own decisions in healthcare? So that, I think, in terms of the bureaucracy, I actually think any large organization, public or private, deals with a lot of the same issues of silos, of how do you stay agile when you need to, right? And yet you don't sacrifice thoughtfulness, right? I mean, there's a whole notice and comment rulemaking. I don't know if you guys know notice and comment rulemaking.
No, it's the Administrative Procedure Act, which governs how agencies like CMS make rules, has a process.
Yeah, so there's a whole process. So all of the payments for Medicare, the payments for the hospitals, the payments for the physicians, it all goes through regulations. These regulations, there's a whole process that has to be followed where you put out a proposed rule, you get comment for 60 days from the public, then you have to read all the comments and incorporate that into finalizing a rule. And when I say comments, our physician fee schedule routinely gets like 30,000 to 60,000 comments. So this is like a significant endeavor, but it's important because as someone was introducing me on a panel once and said, this is Mina Seshimani, she runs the Medicare program. With one regulation, she moves more money than the GDP of several countries. So there is a reason for having that kind of a deliberative process, because when you are talking about a program as big as Medicare, you can make really huge disruptive swings. And so you want to be able to be as thoughtful as possible. However, as you heard, that entire process takes a long time. So what do you do when you have like a COVID pandemic, right? Or when we have to implement drug price negotiation within 2 years. So that's where you try to find where are there those opportunities to still get the feedback you need, but be able to move in a more agile way. But I think that's common. It's a common theme to what happens in the private sector, right? In companies, they have processes by which they make decisions, and there are times where decisions need to be made faster, and what are the avenues that you can use there? How do you handle crisis moments, right? How do you handle mistakes? I think a lot of that is actually common. It just may be done in a slightly different way.
Fritzy?
Thank you so much for being with us tonight. Given your commitment to patient-centered care, I'm curious how you think the health system, whether it's medical schools, government agencies, can better prepare providers to meet patients where they are.
Well, I think the first thing is all of you guys.
Exactly.
I mean, again, I never had the option to have such, diverse backgrounds. I mean, again, like when I was going through training, I think the most common undergrad major going into med school was biochemistry.
Makes sense in your take. Yep.
Yeah, and now I think it's totally different, and I think that's really important. And I think there's much more of a trying to understand how the real world works, and how, you can take care of one person, but it's in this whole system. I definitely still think more needs to be done. I actually give a talk every year at GW to the graduating med students, like Insurance 101. Just like the basics of how do you navigate the system. And I think a lot of that, Medicare does not control everything. We manage graduate medical education funding, so, providing funding for residency training. But a lot of that comes down to the, AAMC, the Association of Academic Medical Centers, ACGME, which is the accreditation body for graduate medical education. So there are a lot of other organizations that play a role in how people are educated and trained going into healthcare. But increasingly, it is about team-based care. It's about knowing what a community health worker does and a peer recovery coach, right? Gone are the days of, people sitting in the hospital for 15 days so that by the time they go home after surgery, their wound is already closed, right? So when I was a resident, I remember going into these poor patients' rooms at 5:30 in the morning for our rounds, right? Okay, you're good enough to go home, and they have this wound that needs to be packed. Who's going to pack that wound, right? And it's going to be a family member or a neighbor who's not necessarily a trained surgeon. So, Medicare is now paying for training for family caregivers so that clinicians can get reimbursed for actually taking the time to provide that training. So, I think there's still a ways to go, but it's not just the government. I think it is, academic institutions, medical societies, everybody needs to kind of, take this into account.
And one area I would say that since, as you all know, I spent quite a bit of time working on income assistance programs, what was AFGC and then became TANF and child care and basically the human services side of HHS. Medical school, it used to be that no one would ever call me from a medical school to talk about those programs. And I really feel like in the last 10 or 15 years, the movement toward recognizing health-related social needs means that the training of physicians, and I think this is true for nurses and other health professionals, is now integrating sort of people who really are completely outside the health sector, which I think is a key part of this as well. So, anyway. All right, so should we get started? We'll start with you, Jordan.
Yeah, what do you wish commercial insurance would cover to prevent illness when patients age into Medicare?
Well, I think there needs to continue to be a focus on prevention and really making sure that people are getting the care they need before they get sick. Because ultimately, if somebody has diabetes or heart disease, if those things are not caught early or prevented altogether, then they come to Medicare with all of these needs. I also think that's why it's so important that people have health insurance, because otherwise you can go for years without getting the care that you need, and then you come to Medicare, and then there's all of these issues, that haven't been addressed.
We'll just go. It looks like everyone's good. So
okay.
Go ahead.
You mentioned how, navigating the healthcare system, we're not in a randomized control trial, so it's very hard to address certain difficulties with the medication itself. What do you think is the best advice for addressing medication adherence rates in the U.S. or just globally? Because there is very low medication adherence rates, specifically for syringes as well as even just pills.
I think that's a really good question because I think there is no one answer. I think this comes back to, I used to lead community health when I was at MedStar, and I would say, what's the first word in community health? Community. Because I think it depends. You could have a situation where there is no trust between someone and their clinician, where their clinician, prescribes something, but the person's like, he or she didn't even listen to me, doesn't know what I'm dealing with. There's no way I'm getting this medicine because I don't need it, right? Or you have someone who wants to go get the medicine and can't make it to the pharmacy, or the copay is too high and can't afford it. So I actually think the most important thing is just putting your ear to the ground and listening, and what is it that people need, so that then you can address that. Because I don't think that there's any one reason, but I think if we all made a concerted effort to really listen to people, we would, come a long way in figuring out how to help them.
And when you think of an agency like CMS, because your lever is ultimately
payment,
money, are there ways to signal or to encourage listening, or is it one of those things that's just, it's really incumbent on the people who are at the delivery end?
No, I think we created payments for screening for health-related social needs, right? So that the time that someone takes to ask someone, do you have trouble getting to the pharmacy or the doctor's office? Do you have trouble paying for your medications? Do you, worry about how you're going to put food on the table? That is something that is reimbursable, so that it's not that someone's feeling, oh, the 10 minutes that I'm spending talking to someone about that is 10 minutes that I'm not doing something else where I could be getting reimbursement. And then from there, we do a lot of partnership with national and local organizations on how to then provide that, because I could walk up to you and say, so you're not having any trouble getting food, right? That's a very different way of asking a question than how is it for you, right? Being able to get food. So I think there's also kind of how questions are asked, how things are, and we can't go into that level of detail in our payment regulations. I mean, our regulations are already 3,000 pages. But I think that's where it's so important that you have partnerships more locally, because what works in one area may not work for another area. So that's where I would tell everyone, come give us your ideas, and then when we put out a reg that has your idea in it, I'm going to be reaching out to you and saying, okay, we did our part, now it's your turn. Take it the last mile so that it has impact.
So let's see, should we just go around, and do you want to go next?
Realizing to a more global scale, do you have any key takeaways from your time at CMS that could be applicable to other countries, or learnings from other countries that you might have incorporated into Medicare and Medicaid programs in the U.S.?
It's interesting because I lived in England for 3 years, but the healthcare systems are so different that I'll be honest, most of what I dealt with was really looking at the U.S. system, because it's just, it is very different. There were people who came to the U.S. who wanted to see how we, did things.
Or not.
Some funny stories there. Really? You have how many uninsured? But yeah, it was much more of a U.S. focus that I was working on.
All right, so let's see. We'll get around those. No, please, go ahead.
I have a couple of mostly form questions, but the one that comes most to mind is sort of the impending cuts to Medicare and Medicaid that are getting voted on tonight or tomorrow. And I was just wondering if you had sort of any thoughts, as a leader or a former leader in CMS, about how that will impact the American people and where those cuts will be felt.
I mean, I think it remains to be seen what is going to happen. I cannot predict at all.
They didn't have the votes before, right before we sat down.
So
but they could before we go to sleep tonight. So
I mean, I have no idea. I don't know what is actually going to get voted on, what's going to pass, what's not going to pass. For me personally, I think it's really important for people to be able to access high quality care that they need, and that I think is the priority for a lot of people. And I think we have to see what comes down the pike and how to try to best address it.
And I'll be less politic and just say it's whatever. There are many things the Medicaid program could be. There are many ways to improve it. I don't know of any of them that would save $880 billion over. But that's just my take. But please, let's see. Who do we? Did you have a? I think you're next. If you got a question.
Oh, she doesn't. Look at her face.
That's okay. Oh, that's all right. You're not obliged to have a question. No, that's. Lily, why don't we start? We'll go with you. We'll go to the back row before we start in here.
Thank you again so much for being here tonight. We're very lucky to have the opportunity to speak with you. I was curious if you could elaborate a little bit on your comment of sort of when you were trying to understand how to sort of make the economics work. Like, for example, chaplains who are not billable for their services. But as someone, I mean, I don't have any kind of economics background or health economics background, but I know from my training as a pre-med student and really interested in public health, like the importance of social determinants of health and all of those sort of non-medical supports. So yeah, I was wondering if you could kind of just elaborate on that from your economics background. And also, I think sometimes those things can get pitted against each other in sort of the rhetoric and how we can try to find common ground on that.
Yeah, I mean, so we'll do Health Econ 101. So in a traditional model of care, fee for service, where you get paid for a service that you provide. So I'll give an example. There was a woman who came into one of our Baltimore hospitals when I was at MedStar, I think 17 times in like 3 months, to our ED because she had chronic obstructive pulmonary disease, COPD, and it kept flaring up and she kept coming into the hospital. So we assigned a social worker to her, a community health worker to her. Community health worker went out to her house, and it turned out that her electricity kept getting shut off, so she couldn't operate her nebulizer, and that's why she kept coming into the ER. Now, and then the community health worker fixed the problem, found the financial assistance for utilities so that her electricity wouldn't get shut off. She stopped coming into the hospital. So one would say that that is a win, right? However, the services of that community health worker was not a billable service. So that was work that was done by the healthcare system that was not reimbursed. And in a traditional fee-for-service model, that woman is no longer coming into the hospital. So the hospital is not getting paid for that woman coming into the hospital anymore. So that's why a lot of the new payment models are about how do we share savings together and have quality metrics. So if you are keeping someone out of the hospital for something that was preventable, then you actually get rewarded for that through quality bonuses. And if you keep someone out of the hospital and that saves Medicare or a commercial payer, that if that saves money, you actually will share in the savings. So that's some of the ways that the newer payment models try to get at what are the imperfections in the more traditional way that the economy worked in healthcare. Does that help?
Yes, thank you.
Just a follow up on that's a great example, but it's super complicated in real life, right? And there can be unintended consequences as you put systems into place. I think the other thing that was really fabulous about the Biden era at CMS was the way you built in experimentation and trying new models out.
Yeah.
Could you say a couple sentences? I think it follows on Lily. Like, all right, so that's the answer, but how do you make sure that the idea of the policy plays out? As
I'm glad that you. Perfect tee-up question. Yes. So, in the Affordable Care Act, right, Obamacare, a new center was created at CMS, the Innovation Center. So that is kind of the R&D arm, if you will, for Medicare and Medicaid. So the Innovation Center tests new models to see if it works to some of what we were talking about. And then if it works, then it can get scaled in the Medicare program. And that was something I worked very closely with Liz Fowler, who is the head of the Innovation Center, to say, okay, what are the things that you are finding that works that we should then scale in the Medicare program? Because again, to come back to what we were talking about earlier, the Medicare program is huge. So if you make a change to it, I mean, that is a huge change. So it's helpful to be able to test something, see if it works, and then be able to scale it up. So we have many examples of that, including paying community health workers. Like, in Medicare, that was something that was tried in the Innovation Center and was found to work, where when you pay for these kinds of supports, it keeps people healthier, keeps them out of the hospital. And so then we said, okay, now we can bring this into the Medicare program overall.
So all right, well, look down here. Anyone else? Are you?
Here I go. We'll go around the room.
All right.
So you mentioned like how preventative maintenance is like the key towards reducing the cost overall. How would you be able to convince more uninsured people and people who are insured and just choose not to go to the doctor? How would you encourage them to keep up with preventative maintenance over time because they just consider themselves like busy or something to choose that?
Yeah, I mean, well, first for people who are uninsured, I think it's really difficult. I mean, there are programs, for example, that HRSA has, Health Resources and Services Administration, to provide vaccines and, colorectal cancer screenings, other things for people who are uninsured. But I do think that's why it's so important for people to have insurance. And I know we are now facing potential cuts to Medicaid, but Medicaid expansion was the remaining, primary way for people to get coverage. Most of the uninsured that remained in the U.S. were in states that did not expand Medicaid, and they tended to be the working poor. People who were working but didn't have kids, childless adults. So unfortunately, I think that gap is going to remain. I think for people who have insurance, I think it really is figuring out what is the barrier for them to be able to help to overcome that. You know, it could be that they don't get sick leave at work, right? I mean, there are many ways in which our system is beyond just what happens in healthcare, right? If people don't get sick leave through their job, then it's going to be really hard for them to make it to the doctor. I mean, one of the things that we are doing in Medicare is we are providing extra payments to primary care practices for providing advanced primary care. One of the things with advanced primary care is offering 24/7 access or having extended office hours or office hours on the weekends, right? So like trying to figure out like what are the barriers. I think another is trust, issues of trust. I mean, this is where I think it's really important that you have diversity in, you know, the training, and that you have people who are coming from all different backgrounds, because again, healthcare is complex and it's really personal, and people oftentimes will feel more comfortable going to someone who has somewhat of a potential shared experience. And, you know, that's why for our graduate medical education funding, you know, we are sending those funds where we can to rural and underserved areas, because you want people to train in the communities that need care, because then they learn what people need while they're still young and learning, and they're more likely to stay in practice. So, you know, again, I think it comes back to your question. I don't think there's like a one-size-fits-all answer, but I think the commonality is just figuring out more locally what the issue is, and trying to address, and realizing that the issue may not actually be an issue within the traditional healthcare system.
Jassy?
Yes. I guess, like, obviously, thank you so much for being here. It was really inspiring to listen to your story. And so, kind of on a different note, I was wondering if you could talk a little bit more about your experiences, like, during the COVID pandemic.
Mm-hmm.
Kind of what were some of the things that you saw, and how did those experiences really inform you or help you in some of your future roles, especially with Medicare?
Yeah, I mean, the pandemic was, first of all, it was horrible, right? And it was incredibly disruptive. And I think, what is the saying? Never let a crisis go to waste. I think it really forced a lot of change very quickly to try to figure out how to address the situation. And I think there are a lot of lessons learned in that. I think telehealth being a primary example. I remember, oh my goodness, we put iPads onto IV poles. Like, we strapped iPads onto IV poles to be able to wheel the iPads into patient rooms so that family members could participate in palliative care conversations. Like, there were all sorts of things like that we had to figure out, you know, on the fly. But I think people realize just the value of a team approach to care, because, you know, there was one person who is Vietnamese who got discharged from the hospital after COVID, and, you know, he and his wife didn't speak English, and they didn't want to go to the pharmacy because they couldn't speak English, they couldn't get the meds, so they called up one of our community health workers, who then went and took care of the prescription, right? There are all sorts of things like that I think really came to the forefront, that I know, you know, when I was at CMS, we were really looking at, like, what are the kinds of innovations that should be continued. There were also plenty of things that we did during the pandemic that were not needed anymore, and so we let those sunset. So there was a whole process that we went to. I think there were 300 waivers that we had to go through at CMS to say, okay, was this utilized? Some of them weren't even utilized. We're like, okay, then we don't need to continue that. Some of them were waivers that, yeah, they were really great, but the law doesn't allow us to continue to do it when you're not in a public health emergency. And then there were others that were like, oh, this was used. People really liked it. People are still using it, so maybe we should make a permanent change to policy.
So I don't know how much of a background you have in, like, the drug approval process, but you had mentioned sort of collecting real world evidence and sort of the difficulty in that. And I'm curious, sort of, how, like, obviously I think that the way that the drug approval process works, there is sort of that cutoff of now the pharmaceutical company doesn't really have any interest in pursuing any more information about how the drug works or, like, how well it works. But I'm curious how changes to that process, and especially how this administration has suggested those changes might happen, like, especially like cutting it down significantly, would make that collection of evidence after approval more complicated or simpler.
Yeah, I mean, I think a lot of what we did on the drug negotiation space was to try to encourage more post-marketing research, post-marketing evidence generation. So, I think that is kind of where we were focused. I will just say, at a high level, you need to have people to do the work that needs to be done. There are people who write regulations, there are people who do approval processes, there are people who do audits and oversight. That, again, to come back to what I think you were asking about the bureaucracy at CMS, I think that's something any organization, right? It's a question of who are the people that you have? Do you have the right skill set? Do you have the right number? Are you engaging them and empowering them in the way that they can be as productive as possible? I think those are things that are very much in the news these days.
Fair enough. And I'll say, less politic, is I think if these are really complicated programs to run. And in my view, the last thing you'd want to do is to make personnel changes without a clear vision of who do you need and the work you need going forward. Just to let groups of people go because they were hired within the last 2 years, for example. That's not
a lot of these programs are highly, highly technical. There were people in the Medicare program 30 years. They know the ins and outs of the program. They forget forget more in the program than I will ever know. And it's really important. The Medicare team was just incredible to work with. Just very mission driven, super smart, nice people who just want to do good and help the 68 million people who rely on the Medicare program.
Do you have a question?
Oh, not a particular question, but I was really interested. Someone else mentioned I study international politics, so I'm interested in the global view. You kind of touched on that earlier. I was wondering what specifically maybe surprised you from taking your first international healthcare systems course in college, and maybe what questions that left you going into your professional career, and kind of where you sought answers.
I think the thing that I couldn't believe was how our healthcare system was formed. You guys know about why we have an employer-based?
Some of them might not, though.
So it's because of World War II and wage freezes and the IRS tax code. That's why we have the healthcare system we have. Completely random series of events where there were wage freezes that were imposed during World War II because of the various economic, because of the economic strain on the country. And so employers started to look at health benefits as a way to attract good employees. And then the IRS changed the tax code to make those health benefits tax exempt. So then employers wanted to put even more into that aspect of compensation because they wouldn't get taxed on it. And that's what basically led to our healthcare system where 161 million people or 171 million people have health insurance through their employer. We're the only country that has that, and it's purely a happenstance of history. And I actually did my term paper comparing how the U.S. healthcare system came to be compared to Sweden. Because Sweden, it was very much a planned, organized, same with the NHS, right?
As you would imagine, Sweden would approach these.
So, but the thing is, everything else trickles down from that, right? The compensation framework for healthcare providers, the educational framework for healthcare providers, and if you look at the difference in tuition between med school in the U.S. and med school in other countries, right? Everything ends up being impacted by that happenstance of history. I thought that was what was so fascinating.
Absolutely. Question?
Yeah, I'm kind of curious. Obviously, at Medicare, you were able to do really historic changes in the healthcare system with drug price negotiations. What are some, main challenges you're still thinking about within the healthcare system that you're hoping to tackle or still think need to be tackled in the healthcare system?
well, now when I go to the state of Maryland.
I was going to say, you've got a whole new opportunity. This is
I mean,
getting you ready for your testimony.
Yeah, right. I still think there needs to be a lot more done to support primary care. You know, I think that we took, like I mentioned, those advanced primary care payments. That was just a first step. And I really hope that that continues to figure out how we can better support primary care and with that behavioral health. I think that's an area that needs to have continued focus. You know, we did a lot on Medicare Advantage as well. Medicare, people can get Medicare directly from the government or through a private health plan. And if it's through the private health plan, then Medicare pays the private health plan a set amount of money to then take care of people. And I actually, with my colleague, recently put out a piece on prior authorization in Medicare Advantage, because the health plans will put into place like various protocols of whether they will allow care or will deny care. And I think that's an area that also needs to have continued evolution of guardrails to make sure that people are getting the care they need and that you are, you know, avoiding wasteful care or abuse. And I think it's important to mention fraud, waste, and abuse are three different things. There's a lot of talk about all this fraud. Fraud is when there is wrongful criminal intent that really can only be determined with, or that traditionally has only been determined with like a DOJ investigation, right? Like we work closely with, you know, with law enforcement for that. Then there's waste, which is some of what, you know, we talk about if you're not coordinating care well, and then there's extra services that really weren't needed. And then you have abuse, which is where, you know, maybe a bill was created and there was a payment provided that should not have been provided for that service. So there are kind of three different things that I think sometimes all get lumped together, that it's good to remember they are three distinct issues with three distinct avenues for addressing.
And they're packaged politically in a nice phrase, but they are different.
As fraud,
Exactly.
but it's not. Fraud is oftentimes it's a
There's
lengthy
plenty
process.
of it, but
it's a process within an investigation to determine if something is fraud.
and interestingly, you may have also read about inspectors general lately, and that the inspector general plays a big role at HHS and other places of looking for fraud in the system. But
Yeah, or looking for improper payments,
Right.
right? Where it may not be something that had that intent, but it's like, hey, you know, here is this loophole. You guys should think about tightening your regulations so that the rules of the road are clearer, right? I mean, there are things like that also. So we definitely worked with our Office of the Inspector General where they would give suggestions, and sometimes you agree with them and you put those things into place. Other times you don't, and you explain why. Like, oh, the law doesn't allow us to do X, Y, Z, or, you know, here's the complicating factor here. So it's very much a back and forth.
you mentioned Medicare Advantage, and I thought it was we had a little bit of a reading on that. So maybe I'd love your take on, you know, there's some sense that CMS is paying too much for Medicare Advantage. At least that's what some say. And then there's more recent information that suggests that people who were on Medicare Advantage and then go back to traditional Medicare incur higher costs in the near term, and there are probably lots of reasons for that. I guess any thoughts you have on, like, how do you think about, is it good or bad is not the right word, but how do you think about the fact that Medicare really has two very different models, and is it good for the American people? Is it good from the government's perspective also? I'm a value purchaser.
Yeah, I mean, Medicare Advantage is 50% of the Medicare population. So I think it's important for people to have options because, again, there's no one-size-fits-all in healthcare. So I think it's important for people to have an option to get, you know, their health insurance, their health coverage from a private plan versus from the government. You know, for example, there are pros and cons to each. In traditional Medicare, you don't have standard, you know, dental coverage or hearing or vision. Medicare Advantage can provide some additional benefits called supplemental benefits. Traditional Medicare doesn't have a cap, an out-of-pocket cost, whereas most Medicare Advantage plans do. So people who take traditional Medicare, a lot of times, more than 90% have some form of supplemental coverage as well. But with traditional Medicare, you can see any clinician in the country who participates in Medicare, which is 98% of clinicians in the country. Medicare Advantage, you can only see those healthcare providers that are in the network of that health plan. And Medicare Advantage has additional prior authorization, to be able to access care that traditional Medicare doesn't. So, there's pros and cons to each. So I think the most important thing is that people need to be able to make a good decision. Right. And, we found there was a lot of misleading marketing happening where people were being switched to a different health plan. They didn't know. They call their doctor in January to make an appointment. Doctor's like, oh, you changed health plans and I'm not in the network of the health plan that you're in. I'm like, what? And then they call us and complain, right? And so we rejected 1,500 misleading marketing ads during open enrollment. We really tightened up our oversight of marketing, like as an example. We did a lot on prior authorization to make sure that, there are clear rules of the road and that people can actually access the care they need. Because when we were doing data analysis, we found that when claims were denied, only 4% of those claims were appealed. So most people, they get a denial and they're like, well, because, healthcare is complicated. They're like, okay, maybe they didn't get the service or, they paid for it out of pocket. Those 4% that appealed, 80% of the time it was overturned. So it really makes you wonder, like, what if more had been appealed? And does this mean that there are denials that are happening that really shouldn't be happening? Because why are the vast majority of them getting overturned, when they are appealed? And so, that's some of the work that we were doing to try to make sure that people are getting the care that they need. And I think that's some of the work that needs to continue to be done. Again, all based on data, all based on meeting with people, hearing, the pain points, looking at our complaint, tracker to see, what complaints are coming in, to know where we should, address things.
Thank you. I just think that's a huge policy question. So let's see now. I'm sorry I skipped somebody.
No, that's okay.
Apologies.
So I found this intersection between health and politics to be really fascinating, especially as a nursing student. Within my clinicals, I feel like it's created a direct impact on patient care, especially now. And I'm really worried what that can mean for patient-centered care and care personalis. And so I'm really interested in hearing your thoughts on how healthcare workers can continue to carry that care for the whole person in a time when there's a lot of unknowns about healthcare.
I think a lot of it is just coming back to the fundamentals of why you went into nursing, right? Why people go into healthcare and doing the best you can in that moment. And I think it's also about using your voice and the experiences and the stories that you have so that people understand the consequences of various policies. Because again, it's also complex that it can be really hard for people to understand how a policy change, what does that actually mean for them, right? And I think that people in healthcare, clinicians, have a very important role in explaining things in both directions. Talking to policymakers about, hey, this is what I'm seeing on the ground, or I really worry if you do X or Y, it's going to have this impact. Or, hey, this is really working, do more of it. And it's also about talking to people so that they understand how to navigate the system the best they can. What has changed to help them. I had one woman, actually while I was here at Georgetown, she came into my office with an enlarging neck mass. She was a young woman, and I was pretty sure it was thyroid cancer just based on history and on exam. So I told her, I said, okay, we need to get a biopsy, so I'm going to send you, we'll get what's called an FNA, fine needle aspiration. And she said, oh no, because my health plan only covers office visits and prescription drugs. Because this was the junk plans, as they call them, or the skinny health plans. And I said, well, okay, but you need to get this taken care of. So it was like October. I told her, I'm like, well, November will be open enrollment for Obamacare. And so I sent her the DC Health link, link for the website, she got enrolled in an Obamacare plan, and then I referred her to one of our head and neck surgeons, and she did have her thyroid removed. It was thyroid cancer. Yeah. But like, it's being able to make that connection for people so that you can continue to help them. And one of the things that I think about is the happenstance that she happened to have an otolaryngologist who worked on the Affordable Care Act legislation and implementation, so I knew exactly, okay, here's what you need to do. I think a lot of people don't necessarily know that, and so one of the things that, we really were trying to do was educate people in healthcare so that they can then talk to their patients, so then again, like, you can feel like you're actually helping them as much as you can, directing to financial assistance or saying, hey, did you know that now the shingles vaccine is free? I mean, the number of times where people were like, I didn't realize that I wouldn't have to pay $200 because people went to go get the shingles vaccine, found out it was going to be $200 or $300, said no thank you. It's not like one morning a 72-year-old grandmother's going to wake up and say, I wonder if the price of that vaccine has changed and maybe I should go check. It's incumbent on all of us to be spreading the news and telling people, hey, you can go get it now. So I think those are all ways that we can all engage.
Especially nurses, I think, are unusually well positioned for that kind of navigating. Last but hardly least, please.
I was just really excited to hear that, like, now you're going to be working on the state level, and I was wondering what opportunities you feel states have in health policy, especially to continue providing access to key care in the face of changes from the federal government.
Yeah, I mean, I think states are really laboratories, right? That's a place that you can innovate, and I think the reason is because you're so much closer to the ground, right? I mean, you can work across, housing and juvenile justice and food, to really drive significant changes. So I think that's what, I'm really excited about.
It'll be a great position. And Maryland's an innovative state, too.
Mm-hmm.
So let me ask, Jenna, are there any people online that had questions?
Yes.
So maybe we take one of those, and then maybe we'll come back to you, too. That will probably be time to wrap up.
So this question is from Annie. So I'm a computer science major and want to go into med school after graduation. With the rise of telehealth and AI in medicine, how are agencies like Medicare adapting to new technology to improve patient care?
That's a great question. These are such good questions. There is definitely, I think, a lot more tech-enabled care that will be important to have. Because, it can help extend the workforce, enable reaching people who couldn't be reached before. I also think it's important to remember that at the end of the day, I'll say again, there is an art to medicine, and healthcare is very personal. And, one of my attendings would say, patients don't read medical textbooks. They don't come into your office and say, well, doc, my chief complaint is, heart palpitations, and these are the symptoms I'm having, right? So, I think that it is figuring out how can you utilize this technology while still enabling a individualized approach so that you don't miss something, and also that the algorithms can continue to mature, because algorithms are only as good as the data that you put in. And we know that there are many issues with healthcare right now. So if you are building an algorithm on historic data, you could be institutionalizing issues that existed, in the past into the future. And so how do we make sure that there's that continuing evolution?
Babe?
So I'm curious, I was just brushing up on the Wall Street Journal that came out in August, I believe, talking about your collaboration with Pfizer and just the negotiating drug prices in general. I'm curious your thoughts on how the drug makers responded, asking how does CMS pick the medicines it's used for comparisons? And additionally, kind of to flip that question on its head, how do you think these companies pick their price for these drugs?
So we put in our guidance how we picked what's called therapeutic alternatives. So we said, we want to understand how these drugs work. So we're going to identify what are alternatives to these drugs so we can see how are these drugs that we're negotiating, how are they different. So that's the therapeutic alternatives. And we had a whole methodology that we had put, again, we proposed it, we got comments on it, and then we made changes and we finalized utilizing clinical compendia, clinical guidelines, like what are alternatives for the treatment. So that's basically how we selected those alternatives. What was the other?
How do you think these drug makers set their own prices for these drugs?
I mean, I think, there are probably various factors that go into it. I'm not privy to, what factors go into how they are, setting prices. I think one of the things that we wanted to be able to move the needle on in establishing the drug negotiation program was to bring some more transparency and some more data to the conversation of drug prices.
I'd just add that I think just looking at drug prices across countries leads you to believe that there is an analysis of what markets can bear in addition to the therapeutic value. But those are my words, not yours. But I think that is a way to think about it. But I think we probably have time. If there is one more question, I'm happy to take it. If not, what I'll do, maybe ask you as a final word, it kind of takes us back where we started the conversation. Everybody here.
Back to New Jersey?
Back to New Jersey. Well, actually, I'll take you out of New Jersey. You're Brown now. If you're, well, everybody here got to hear tonight what an amazing mind and commitment you have to healthcare. It's really breathtaking. It's really cool. But now you're put yourself back to it. You're 21 or 22, and you're thinking about how you can make a difference. Folks, some people are going to go into medicine. Some are going to go into other areas. Some may never touch health at all. But for those who do, how do you get ready for this next era? There's a lot of change, technological change. We're going to see changes, I think, in the way some of our public programs work. What's the right way to? What thoughts do you have as people imagine their career now? Like what do they keep in mind?
I mean, I think it comes back to figuring out what you love to do and then doing it. Figure out what brings you joy and how you can have an impact and how you can bring your skills to bear, and then throw yourself into it and be open to opportunities. Be a good person to work with, and keep yourself open to opportunities that come along so that you can have the biggest impact that you can. And another thing that I will say that Secretary Sebelius told me, in addition to telling me she would fire me if I didn't go back to residency on my own, at one point, I very much believe in humility also. I think a lot of what I was able to do in Medicare was because I readily admitted that I did not know the answer, right? Like a lot of what I did was going around and talking to people and having them give me ideas and then implementing them. It wasn't me sitting on my own and coming up with all of these, grand ideas. A lot of it was having that humility to say, I don't know, so I want to work with all of you and figure it out. At the same time, Secretary Sebelius at one point also told me, Mina, you have to own your excellence. And like when you can do something well, go do it. And have the confidence that you can make a difference. And it may not be perfect, but rarely is something ever perfect. And if you approach something with all of your heart and all of your mind and you do the best you can, and you do it with good mission and intent, I think your career will be exactly wherever it was supposed to be.
It's an excellent way to end. I guess I'd ask everybody to join me in a round of applause for Dr. Seshaman. This is the point of this course is a little bit of what you heard tonight and what we're going to hear in future sessions. There is a way to take your passion and your belief that you can make a difference and navigate your way. But I would encourage you to also note that every speaker we've had so far didn't know that they'd be where they are today when they were sitting where you were. It meant keeping their minds open and looking for the opportunities that are out there. So. And
reach out to people, right? Like if you want to do something, cold email or call that professor who has a research project, or be like, hey, can I get career advice from you? Because you never know where things will lead, what bit of information you'll pick up, what relationship you'll develop. I mean, having mentors is so important, But like mentorship is a two-way street. Like you have to engage and say, hey, here's where I'd really like some advice, or can you tell me about X? Like, so I really think it's very important. Things won't just plop out of the sky for you. It really is about making yourself available and known. And I personally think a lot of that is done through demonstrating your character and your integrity and your passion and your, hard work and what you can deliver, and then things will happen however they're meant to happen.
People stand out the way Dr. Sishimani did in 2000.
I had no idea.
2009.
When we were in the basement of HHS.
I've been through a few of these things, but not everybody stands out this way. So my point is, I think your point is well taken. Take advantage of the chance to shine, and people will see that. So anyway, thanks everybody. We'll see you in a couple weeks, and applause again.
Thank you.